Welcome everyone. My name is Julie Magnuson, and I am the USIDNet project manager here at IDF. I will be your moderator for this education event today. Today, Dr. Ramsey Houlihan will be presenting on long-term follow-up for hyper IGM. There will be time for questions at the end of Dr. Houlihan's presentation. Please submit any questions you have to the presenter in the Q&A section of the platform. Dr. Ramsey Houlihan is the clinical director of the Division of Pediatric Allergy, Immunology, and Rheumatology, and a professor of pediatrics at Columbia. Throughout his career, his main research interest has been the pathogenesis and treatment of primary immunodeficiency diseases. Dr. Houlihan was formerly chief of the Division of Allergy and Immunology at Cedra Medical and Research Center in Qatar, and the director of Primary Immunodeficiency Clinical Services and the Jeffrey Modell Diagnostic and Research Center for Primary Immunodeficiencies at Anne and Robert H. Lurie Children's Hospital of Chicago. Dr. Houlihan earned his medical degree from the American University of Beirut in Lebanon, completed his pediatric residency at Duke University Medical Center, and a fellowship in allergy and immunology at Boston Children's Hospital at Harvard Medical School. Welcome, Dr. Houlihan.
Thank you, Julie, for the kind introduction. Thank you for the invitation to speak. This topic is very close to my heart. Although the exact title, we don't have a lot of data or publications to enlighten us on what to do with long-term follow-up. So I thought we'll talk about the disease, talk about some of the important issues that may impact long-term follow-up. I wrote down a few things at the end, and then maybe in the discussion and questions, we'll maybe come to some agreement or some ideas to pursue to try and sort this out. Oh, sorry. Okay. So primary immune deficiency diseases like X-linked hyper IgM result from single gene defects that affect one or more components of the immune response. As a result, there's increased susceptibility to infection, sometimes malignancy, and sometimes autoimmunity. And we're now appreciating that what we call inborn errors of immunity may not only result in immune deficiency, but may also result in immune dysregulation, leading to inflammation, autoimmunity, and as well as immune deficiency diseases. Primary immune deficiencies really were not recognized or identified until antibiotics were discovered. Before then, it wasn't unusual for patients to succumb to an infection. And the first description of a primary immune deficiency disease was in around 1950. As a result, patients of an immune deficiency, patients have a susceptibility to infection, and that can be because of a defect in the innate or adaptive immune system. You have to be exposed to the infection, and some immune deficiencies associated with give you susceptibility to opportunistic infections, which otherwise would not cause infection in a normal host. And this can be found in the host themselves, in the water, in the environment. If you have a break in the skin or mucous membrane barrier, that can lead to infection. And so you can think of the skin and mucous membranes as like our first line of defense. And then if we are unable to drain the respiratory tract, whether it's thick mucus and cystic fibrosis, or the cilia don't work, or other causes of inflammation, that block drainage would lead to an infection as well. So it's not all really inherited immune deficiency. X-linked hyper IgM was discovered about 10 years after X-linked agammaglobulinemia, and it's a rare inherited immune deficiency. It was described by both Fred Rosen in the USA and by Dr. Burton in Switzerland. Patients are susceptible to recurrent upper and lower respiratory tract infections. They are susceptible to opportunistic infections, including pneumocystis jirovecii in the lungs and cryptosporidium in the GI tract. Many of them have neutropenia. There's a higher incidence of cancer, luckily not in too high a percentage, but it's higher than in the normal population for some cancers. And the disease is characterized by an inability to produce antibodies other than of the IgM type. And IgD is mostly on the cell surface. So as a result, they have low or very undetectable levels of IgG, IgA, and IgE. Some patients have some IgA, but they all have normal or elevated IgM. And now that we're able to recognize immune deficiencies better and make a diagnosis earlier, it's maybe unusual to see very high IgM levels. And so the disease a little bit is sort of a wrong name, but many patients will have normal and occasionally even low IgM. Now, if you immunize patients, they make IgM antibodies, but they don't switch to any IgG antibodies. And if you do a booster, you still get this primary antibody response. You never get a memory response. And back in early 1990s, 5 groups discovered the cause of X-linked hyper IgM as a pathogenic variant in the CD40 ligand gene. And here's looking at CD40 ligand expression in a normal individual. The T cells have to be stimulated. At the time, we didn't have monoclonal antibodies, but we used a soluble form of CD40, which should bind to its ligand. And you see a good number of cells in the normal individual binding to CD40, but none in 2 patients with X-linked hyper IgM. And we used a different cell surface activation marker, in this case, CD25, the IL-2 receptor alpha chain, which gets upregulated with stimulation, and patients express CD25 fine. If you look at the patient's lymph nodes, you find they lack the germinal centers, which is where this interaction between T cells and B cells happens, and where isotype switching and somatic hypermutation take place. So why is this important? Well, we need to make antibodies of different types to have different functions. A B cell first makes IgM and IgD, and then switches to either IgG, IgA, or IgE. And these antibodies are made by B cells, and they fight infection by binding to and destroying microbes or neutralizing their toxins. They can neutralize viruses and toxins. They can clear extracellular pathogens and their toxins. They can clear intracellular non-enveloped viruses via a high affinity intracellular receptor for IgG. They help phagocytic cells take up microbes by opsonizing the microbes with or without complement. They can lyse microbes on their own through complement activation, and they help target cells for natural killer cell antibody-dependent cellular cytotoxicity. So, very rough schematic of an antibody molecule. It has it's made up of 2 identical heavy chains and 2 identical light chains. At this end is the variable region that binds to the pathogen or the proteins from the pathogen. And at this end is the constant region, which determines what type of antibody it is and therefore determines the function. So when an IgM, a mature B cell that has IgM and IgD wants to switch, it can't do it on its own. Until this stage, it is able to develop without any help from T cells. But when it wants to go further, it needs CD40 ligand from the T cell interaction to cause immunoglobulin isotype switching, either to IgG, IgA, or IgE. And also memory B cell formation is necessary. At this stage, also B cells become plasma cells and secrete immunoglobulin. So why is that important? Well, these antibodies have different functions. IgG are best at neutralization. IgA has good function there too. IgG molecules are also good at opsonization and NK cell cytotoxicity. IgE molecules, which cause allergy nowadays, but are there to protect us from parasites, sensitize mast cells to help kill off parasites, and nowadays cause allergic disease. IgM is very good at activating complement, so is IgG. IgA crosses the epithelium, and so it protects us at the respiratory epithelial sites and then the GI tract. And it also goes into breast milk, so protects the baby's GI tract and upper airway. And IgG transported across the placenta, so when the baby is born, it has its mother's IgG level, which slowly decreases over time, and then the baby starts making its own. And by 6 months is the lowest level, and then it starts going up again. And IgG is a smaller molecule than IgM or IgA, so it can get out of the bloodstream and go outside the blood vessels. So what happens when you have X-linked hyper IgM? These were 2 registries, one from the United States, led by the Immunodeficiency Foundation, and one from the European Society. And I put them together to see. We had a total of 135 patients. Most of them had pneumonia. About half had the opportunistic infection with pneumocystis jirovecii. Many had upper respiratory tract infections. About 2/3 of the patients had neutropenia. About half were chronic and half were intermittent or cyclic. Then there was a good number of patients with diarrhea, anemia, oral ulcers, sepsis, meaning infection in the blood, liver hepatitis, sclerosing cholangitis. This could be usually from a cryptosporidium infection, but not all the time. And there were also some infections of the brain and central nervous system, as well as a few cases of cancer. And the causes of death in these patients, where the age of death ranged from 9 months to 25 years. And most of them were from infection, as early as 9 months from pneumocystis jirovecii and a staph infection, some with cytomegalovirus infection, even TB, and encephalitis, meaning a viral infection of the brain. Liver failure was next in frequency, sclerosing cholangitis before or after liver transplant, and liver cirrhosis, as well as hemolytic uremic syndrome, and then a few cases of hepatocellular carcinoma or primitive neuroectodermal tumor of the colon. So these are patients with X-linked hyper IgM, but there is a phenotype that patients present that is the hyper IgM phenotype with low IgG and IgE, but normal or elevated IgM. And I'm taking IgA out of the equation, which can be seen in males or females. And thus it was thought these patients have potentially would have an autosomal recessive, because they're affecting girls as well, affecting females, and it seemed that they have defects in CD40 signaling, confirming sort of that the defect is not just that it's CD40 ligand, but it is the inability of CD40 ligand to bind to CD40, and then for CD40 to signal. And in this case, it is autosomal recessive. So I'll show you a scheme of how this works. Any antigen-presenting cell, but in our case, we're going to talk about a B cell. Once it takes up a pathogen, it breaks down some of the proteins and presents a fragment from the protein via MHC class II molecules to the antigen receptor of the T cell receptor, which is closely bound to CD3, which is a molecule or a group of molecules that define sort of a T cell. This activates the T cell, and it does a number of things, but one of them is to express CD40 ligand, which normally at rest would not be there. So once CD40 ligand is expressed, it binds to CD40. CD40 then does a number of things. It upregulates B7 molecules that co-stimulate the T cell and are helpful for T cell differentiation, release cytokines which help T cells differentiate into their function. And then it activates downstream enzymes that turn on the switching from IgM, IgD to IgG, IgA, or IgE. It depends on, there's also a cytokine secreted by the T cell, and that cytokine helps drive which of these immunoglobulins will be formed, and also causes somatic hypermutation, which is the process by which an antibody molecule can have a much higher affinity for the pathogen, and therefore we get more effective antibody. So both of those are activated by these enzymes. And so if we have a defect in CD40 ligand, we have X-linked hyper IgM. A defect in all the others are autosomal recessive. It can be in CD40 or in either of adenosine activation-induced cytidine deaminase or uracil and glycosylase, and also gives you autosomal recessive hyper IgM. But these two groups of defects or diseases are different than these, because these affect everything downstream of CD40. And as a result, these patients have more than just an antibody deficiency. They have opportunistic infections and a susceptibility to these opportunistic organisms. These patients don't usually have opportunistic infections. They tend to have large lymph nodes because everything is happening, but they're not able to make antibody. And so they can have problems with large adenoids and sleep apnea, and have large lymph nodes, and they're a little bit more likely to have autoimmune disease than the X-linked or CD40 defect. I just went over that really. And the defects that are limited just to the B cells, so AID and UNG, you get recurrent upper and lower respiratory infections. Rarely would you get opportunistic. I think you don't. There are large lymph nodes. In these cases, we tend to see higher IgM levels, and there may be some autoimmunity. So how do we treat hyper IgM? Well, patients can't make antibody, so we need to replace immunoglobulin, and we can replace IgG. It can be done IV every 3 to 4 weeks, starting at 400 to 600 milligrams per kilogram per dose, or it can be done subcutaneously every 1 to 4 weeks. And of course, if there's any infection, we want to treat it aggressively. We would like to prevent pneumocystis infections with trimethoprim sulfaperoxidol or pentamidine. If patients have significant neutropenia, they can just get GCSF. If we use a lot of it, we worry about long-term side effects. Stem cell transplantation is available for X-linked hyper IgM or CD40 deficiency if there's a good matched donor. And a big question has always been, if we start treatment early, can we reduce the infection-related complications? But some of these complications are very difficult to prevent, particularly when we get to sclerosing cholangitis, liver disease, and some cancers. So our goal for treatment is to prevent infection, reduce the frequency of infection, reduce the severity of infection, and allow a normal lifestyle. So historically, at first, when X-linked agammaglobulinemia was discovered and described, patients received plasma transfusions to help reduce infections, but that didn't really raise the IgG levels very much. Eventually, they were able to prepare preparations of immunoglobulin that can be given intramuscularly. They were not purified enough to be given intravenously. And so again, you can't do too much intramuscularly. You can't get a big elevation of the immunoglobulin. Once IgG was purified to allow intravenous infusions, we were able to achieve much higher serum IgG levels. And so we give this every 3 to 4 weeks, and we obviously have a peak, and then just before the next infusion would be the trough level. Subcutaneous immunoglobulin has been around for a while, but now we have specific preparations with higher concentrations than we can give in the IV preparations. But initially, even the IM preparation could be used subcutaneously. And now infusions are given from 1 to 4 weeks, depending on the product, depending on what the patient would like. And this gives a little bit more constant levels of IgG without that much variation between the peak and trough. Our products safe, they are, the industry has, as well as FDA, of course, FDA is required, and the industry has been very proactive in trying to keep the product safe. The donations only come from healthy donors with 2 forms of ID. They have to have a local address. Any donation is held for 60 days until the donor comes in again. Otherwise, the donor is considered unreliable and it's not used. And the second one also waits for the third, and so on. Most donors are repeat donors, so that the centers get to know them. All the products in the US are derived from plasma from the US. They look at antibody to viruses, as well as look at viruses by PCR to see that there aren't any in the samples. Luckily, HIV was never transmitted with IV gamma globulin. In the early 90s, we had an issue with hepatitis C, but now we've learned more about hepatitis C, and we've changed how the companies have changed how they treat the preparations, and there are tests now for prions as well. The side effects of treatment are transfusion-like reactions, fever, chills. It is possible to have an allergic reaction in somebody who's totally IgA deficient, but you also have to be able to make IgE or other antibodies to the IgA. So it's not that common. You can get headaches, and it can be as severe as an aseptic meningitis. Ibuprofen usually helps, as well as slowing the rate of infusion, but also switching to subcutaneous might help. There have been some cases of renal dysfunction and thrombosis, but they're rare. There's maybe some transient neutropenia. And since hepatitis C, there has not been any transmission of bloodborne viruses. Whereas subcutaneous IG therapy, the side effects are more local, although occasionally there are some systemic side effects. So if you look at the IgG levels in patients, in the old days, we liked troughs of 600. Now we'd like it to go higher to 800, but let's say this is 600. You get a big boost after the IV infusion and gradually goes down. And then you want to be over 800 for your next infusion. This is here a 3-week, but sometimes we're able to do this every 4 weeks. Whereas with weekly sub-Q, you tend to have more stable levels. There isn't that much of a change. We like this, therefore, to be higher than the 800. We'd like it to be more around the 1,000 because that's where you are all the time. Whereas when you're at trough 800, all the 3 weeks, 3 to 4 weeks before, you're much higher level than 800. So we know that there's increased life expectancy. We know there's reduced frequency of bacterial infections. This is for all immunodeficiency in general. We know that the more we delay diagnosis and start of therapy, the more morbidity there is. And we know that higher doses give us decreased rates of infection. And there are other therapies for hyper IgM. Some people have tried CD40 agonists. They tried a recombinant CD40 ligand. It was made to try and fight some cancers, and then it didn't work, so they stopped really making it. But even with X-linked hyper IgM, it didn't work too well. It helped. It did not correct specific antibody synthesis. It improved some T cell responses, improved secretion of cytokines, and maybe changes in the architecture of the lymph nodes, but it wasn't a dramatic response. They tried an anti-CD40 antibody, and it helped a little bit in a higher dose in one of the patients with cryptosporidiosis, but it failed to cure disease. But it did cut down the shedding with the higher dose or the more frequent dosing. So these are not really very, unfortunately, appropriate treatments. In general, many patients ask about alternative therapies, and really, in most cases of primary immune deficiency, there is no really supplement or vitamin that is going to correct the immune deficiency. Probiotics help provide a healthy microorganisms in the gut, but some cases of severe immunodeficiency may be susceptible to infection by less pathogenic microorganisms. So I'm okay with sort of natural yogurt, things like that have probiotics, but in a more severe immune deficiency, I'm not sure I'm comfortable with giving sort of probiotics directly. So how about transplantation? And that's really, a lot of times it's a very big question, because as you saw, some patients do well over a long period of time. And although there was a significant number of deaths in X-linked hyper IgM, the majority, were still alive. And so it's not like a severe combined immune deficiency where we have no option really but to transplant. The pros, I guess, of stem cell transplantation is a potential cure, but there is a risk for complications. But there are novel approaches that seem to be working better. And so here's a study from the European experience where they had 130 patients transplanted between 1993 and 2015. They actually had a previous paper where from 1993 to 2002, and then they added another 13 years. And they looked at the year of transplant, before or after 2000, the age of the patient at transplant, less than 5 years, between 5 and 10, more than 10, any infection prior to transplant, any organ disease or damage, and then what stem cell source was used, bone marrow, cord blood, peripheral blood, was the donor a matched sibling versus unmatched unrelated donor? Did they do a full myeloablative or reduced intensity conditioning? And how long did the patient wait between diagnosis and transplanting? So this is a lot of data. I'm going to show you just one really, which is the age of hematopoietic stem cell transplantation. And you can see that transplantation after 2000 was better than before 2000. Here it's but also younger age of transplants was better. So this is patients over 10 years old. Again, after 2000 was much better than before 2000, but transplanting before 10 years is definitely much better. And if we go back, as you would, it just follows common sense. If you're better off if there was no infection, and next off would be that the infection is treated, you're better off if there's no organ disease or damage. Chronic lung disease, bad liver disease were poor outcome. Here, they found bone marrow was the best. The experience of my colleagues when I was in Chicago was great with peripheral blood. So I don't know if it's if here we need more and different analysis, considering the donor with the type of type of where the stem cell came with the type of conditioning, because the Chicago group always used reduced intensity. But in any case, we want to find, of course, the best matched donor. And again, matched siblings are always better than a matched unrelated. But nowadays, matched unrelated do very well. And then another international multi-center study to look at the benefits of stem cell transplantation looked at 176 patients that were diagnosed between 1964 and 2013. And about 38% received the stem cell transplant. If you looked at all the data, there was no change in survival, but there was definitely improved quality of life and decreased risk of cancer, as well as other risks. And it seemed that the risk associated with stem cell transplantation decreased between 1987 and 1995. So the more recent transplant protocols seem to be doing better. And also they found that transplant at an early age was associated with improved survival. And finally, sort of gene therapy for X-linked hyper-IgM. Now we have a number of immune deficiencies that can be corrected by gene therapy. For X-linked hyper-IgM, there are a few issues. One is that the gene defect is not lethal to T cells. So in severe combined immune deficiency, it is, which allows even inefficient correction to produce T cells, and they don't have to compete with, in the case of CD40 ligand, any corrected T cells or stem cells would have to compete with T cells that have a non-functioning CD40 ligand. So, and then if you add a normal CD40 ligand to an abnormal one, well, some of the defects can interfere with the activity of normal CD40 ligand, because you get about 3 molecules put together. Regulation of CD40 ligand is very important. If it's overexpressed, it tends to be associated with autoimmune and lymphocytic disease. So you may need to correct the defect in the gene directly instead of adding a normal copy of the gene. And now there are new approaches for this. You probably heard even in the news about gene editing, and there are various groups using either TALEN-induced double-strand breaks in the chromosomes or CRISPR-Cas9, and sending a normal gene through an adeno-associated virus. It's just not efficient in stem cells yet, so there's more work need to be done, but potentially something that can happen down the road. Sorry, I didn't correct the color of the title. So what would be, our goals of therapy would be the same, but what do we need to do with long-term follow-up to maintain those goals that we have for hyper-IgM as we do for other primary immune deficiencies? Well, we want to prevent infection. So here I'm talking about patients who have not had a bone marrow transplant, stem cell transplant, but even some of the patients sometimes require immunoglobulin replacement. So we need to maintain adequate immunoglobulin replacement. Big question on when to stop PJP prophylaxis. And I've seen older teens, young adults who are off the trimethoprim sulfamethoxazole, but also one of my patients in his 20s was admitted many years ago to an intensive care unit with pneumocystis pneumonitis. So that sort of caused, I have not therefore stopped patients' prophylaxis and probably advise continuing. Cryptosporidium is very hard to eradicate, and I was reading articles in preparation that even they become resistant to chlorination. So a clean water supply is important. And I used to think chlorinated water, city water, would be fine, but it seems like maybe boiling is the only option to really clear cryptosporidium. You definitely want to monitor for complications. I don't know that there's direct testing for complications, but if the patient has diarrhea, definitely want to test for cryptosporidium. There are some treatments for it now. Neutropenia, if it's causing infection or side effects, mouth sores, fevers, you would want to consider treatment. But I've had patients with very, very neutrophil counts who did not seem to have infections from that and did not seem to need GCSF. And any cognitive changes, because there have been some reports of neurodegenerative disease in different immunodeficiencies, including X-linked hyper IgM. And so these need to be addressed right away and have neurology and maybe infectious disease involved. Again, here the title is long-term follow-up for hyper IgM. I apologize about the color. So in general, I think if there are no infections complications, every 6 months is reasonable to follow up with your immunologist. And if things are going really well, it could be every 12 months, but I'm not sure I want to commit to 12 months in public at this point. We usually like to just make sure blood counts, liver, kidney, immunoglobulin levels are fine every 6 months while patients are immunoglobulin replacement. Lymphocyte subsets in general are not affected in the hyper IgM syndromes, but it's not unreasonable to check them every couple of years, maybe even longer, as if they are always stable. For patients who've had a stem cell transplant, then follow-up is really driven by the stem cell transplant team. And initially, it's a very frequent follow-up, but it then goes back to like yearly to examine immune reconstitution, donor chimerism, immune function. And sometimes they'll go longer than that, but I think it's important to keep close watch, because sometimes you lose donor chimerism, you might lose the healthy cells. And in summary, so primary immune deficiency diseases, including hyper IgM syndromes, are rare defects of host resistance, and we've learned a lot from them about normal immunity. Of course, we have also better therapies for them. We hopefully will even have gene therapy for hyper IgM sometime soon. So as we discover more defects and discover more options for treatment, we are developing more specific therapies, and hopefully there'll be more for all the different immunodeficiencies. Ready to take questions.
All right, thank you so much, Dr. Philahan, for sharing that wonderful information on hyper IgM for our community. We now have some time available for Q&A, but before we begin, please remember that everyone's treatment and condition is unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. All right, now again, you can go ahead and submit any questions that you have in the chat. Likewise, as the chat stated, if your question does not get answered during these sessions, you can always ask IDF by going to our website, and a member of our team will assist you. So again, if there are going to be no questions too, then I believe our time together could end here soon, but I'm going to give everyone another minute or two if they'd like to go ahead and submit their questions. All right, as I say that. All right, so our first question here, Dr. De La Moreno's 2016 paper, long-term outcomes of 176 patients with X-linked hyper IgM, found that there was no difference in survival was observed between patients treated with or without HCT across all diagnosis years. Do you feel this is an accurate assessment, or maybe the data was skewed because of the inclusion of pre-2000 HCT data and survival rates? Would you still recommend HCT, assuming a good match based on the published data over not doing HCT and continuing?
Yeah, I think, and this is from that paper, and true, like overall there wasn't, but I think there seemed to be, when you looked at transplant in later years, there seemed to be a better outcome. And if you look at the European paper, you see a clear difference between transplantation after 2000 versus below 2000. It seems the millennium was really important for bone marrow, for stem cell transplantation, and it may just be an arbitrary cutoff. But I think if there's a good match, I would recommend it. But it is definitely a family decision, parents' decision of what to do. Even in Dr. De Morena's study, which did not show an overall change in survival, the quality of life was improved, and there's a decreased risk of cancer and other complications of the disease, which are very meaningful. But it's not an easy decision in a disease where you can have good long-term outcome. It really boils down to sort of the family's preference, working with their physicians to decide. I think every patient should see a transplanter, know what the options are, know what the risks are. Doesn't mean you're doing it. It just means you're getting all the information, and then hopefully you can make that decision. But I think the European data is pretty, it shows that transplant nowadays in a young child has much better outcome. But I'm talking about the majority who survive, and there are those who don't. And I don't know if you can correlate that with, are they going to have more trouble? Would they have had more trouble as patients? We don't have that data. So that's where it makes it a difficult decision. But for close to like 90% of patients, it would be a good outcome.
Thanks, Dr. Pulahan. We do have some more questions coming in here. All right, the next one says, I have very high IGM combined with low IgG, IgA, but have been diagnosed with CVID and not hyper IgM because I have no defect in the CD40 ligand. Does the label make a difference given that the treatments are so similar?
That's a very good question. And I don't know how extensive a genetic testing was done. But now with our panels that would look at over 400 genes, and some are associated with CVID. And of course, we have a few that are with the hyper IgM. It doesn't have to be X-linked. It could be autosomal recessive. The difference is CVID is a group of different diseases that have similar phenotype, so they're not all the same. We know there are a group of CVID patients who only have infection, some who, there's 10% who don't have infection, but they have autoimmune complications, and there are many who have autoimmunity, GI disease. And so there are complications CVID, but it's rare to have the opportunistic infections that you see with CD40 ligand. There's maybe association with lymphoma, but not with the liver cancers or the primary neuroectodermal carcinoma. So there are differences, but it really the diagnosis should be better sorted out. We still don't know all the genetic causes of CVID. Both CVID and hyper IgM will have low switched memory B cells. And not every elevated IgM is the hyper IgM syndrome. So I hope that helps. But if the genetic testing you had was very limited, I would recommend maybe doing a larger panel. The issue with big panels is that you're likely to see a bunch of variants, and they're not always variants of, mostly they will be of unknown significance, and sorting them out is not your responsibility, your physician's responsibility. But hopefully, as long as you understand this might happen and won't be anxious about it, then it would be good to get more extensive genetic testing.
Thanks so much for that answer. We do have another question here. What is your opinion on the long-term use of prednisone to treat autoimmune symptoms in patients with immune deficiencies, especially when the symptoms have been resistant to biologics and other medications?
Oh, that's a very tough question. I was going to say we now have more specific treatments for some causes of autoimmunity, and we can avoid sort of long-term steroids. Nobody likes long-term steroids, but no one likes the complications of autoimmunity. So it has to, I'm sorry, but this has to be sort of a very general answer. Again, it'd be important to try and understand what's the cause of this autoimmunity, and if there are specific targets for therapy like JAK inhibitors or some other biologics, and to find the appropriate biologic. But autoimmunity has to be controlled. So if the only option is steroids, we will want to find ways of reducing the side effects if you can get to like every other day steroids, or if there's any other possible steroid sparing additional therapy that can help.
Great, thank you. Well, if there's any more questions, again, please go ahead and submit them in the chat. We do have a few more minutes here. But these are, I know, good questions coming in here for today.
If anybody has like comments or questions about how they feel long-term follow-up should be, and obviously, you know, if we could identify complications before they happen, but we don't have good tools for those yet.
All right, wonderful. Well, it looks like if there's going to be no more questions, then I think our time together has come to an end. Thank you so much, Dr. Houlihan. It's really been an honor to have you join us today.
Thanks.
Enjoy the rest of the conference.
Unfortunately, I can't see anybody, and I love doing this in person. So hopefully in the near future, some of these can be done in person and we can see each other and chat and so on. But good luck to everybody. And thank you for having me.